Hi, my name is Michael Johnson. I'm one of the residents over at White River Medical Center in Batesville, Arkansas, and my case is about chronic peripheral arterial disease. We had a 59-year-old man come into the ER after enduring many weeks of pain in his left foot that was worse with exertion. He had a long history of cardiovascular problems which were related to diabetes and smoking. Physical exam revealed a cool extremity with non-palpable pulses and dry gangrene, but at that point he reported minimal pain at rest. MRI proved acute osteo in the second and third toes, IV antibiotics were started, and orthopedic surgery was consulted for amputation. This patient had severe anxiety about losing his leg, especially when amputation was recommended, and he was desperate to try to save his limb in the endovascular lab. With no signs of sepsis and blood cultures showing no evidence of systemic infection, cardiology service was brought on board to attempt revascularization on hospital day 4. In the vascular lab, the patient's leg was noted to have over 60 centimeters of chronic total occlusion extending from the left common iliac all the way to the popliteal artery. The only option for access on the left side, distal to that occlusion, was through the left posterior tibial, and over a guide wire, the ocelot device was used to cross that chronic occlusion, starting at that posterior tibial, moving proximally all the way up to the common femoral, iliac, and then connecting with the aorta. Drug-coated balloons were used to dilate and improve flow in the iliac and SFA, and stents were applied to the external and common iliac arteries, all with excellent expansion and no evidence of dissection or perforation. This patient worked well with physical therapy, able to maintain his mobility, was up and using the rolling walker, ambulating, performing his ADLs on his own just a few days after the procedure, and then was discharged home with outpatient rehab on hospital day 10, kept on dual antiplatelet therapy with a close cardiology follow-up. Lower extremity peripheral artery disease affects 12 to 20% of Americans aged 60 and older, which is approximately 12 million people in the United States. Intermittent claudication is the hallmark of atherosclerotic disease, but occurs in only about 10% of patients, and 40% may have no leg symptoms at all. Atherosclerosis is the major cause of lower extremity PAD, getting that waxy substance called plaque building up in the inner lining of arteries made up of fat, cholesterol, fibrous tissue, and calcium, demonstrated in the top right, reducing blood flow, if not fully occluding it, and blocking flow through major arteries to the limbs. The most significant risk factors for PAD are hyperlipidemia, hypertension, diabetes, chronic kidney disease, especially ESRD, and smoking. Having any of the 3 of these factors together confers a 10-fold increase in the risk of PAD. Current guidelines recommend resting brachial, ankle brachial index testing, ABIs, for patients with history or exam findings suggestive of PAD, but not routine ABI screening for those not at risk. Interval ABI results can also be used to monitor the efficacy of revascularization pre and post procedure. Criteria for the diagnosis of PAD is an ABI equal to or less than 0.9. It's graded as mild to moderate if the ABI is between 0.4 and 0.9, and an ABI less than 0.4 suggestive of severe peripheral artery disease. Patients in that mild to moderate category are where you start to see the intermittent pain with exercise in the legs. And patients with an ABI at 0.5 or below are likely to start having pain in the legs even at rest. An ABI less than 0.4 shows that you have increased risk for limb loss, gangrene, ulceration, and otherwise delayed wound healing. ABIs greater than 1.3 are also considered abnormal, suggestive of non-compressible vessels. These graphics show the ocelot device itself using the Seldinger technique or over a guide wire that has spiral channels to bore through those chronic occlusions. And it uses near-infrared light to visualize the lumen to make sure what you're going through is plaque and not the vessel wall itself. It's just one of several techniques currently in use to address chronic occlusions. But in this case, we were able to use it to clear over 60 centimeters of major arteries and help salvage this patient's leg. He's been up and moving for a year and a half post-procedure, giving hope that even chronic occlusions can be removed safely. If you have any questions, my email is mjohnson6@whiteriverhealth.org. Thanks for your time.